With that being said, I say to you, thank you, good night, and a happy Reagan Day dinner night. Thank you.
We're live from Capitol Hill, where the House Veterans Affairs Committee is holding a hearing on suicide prevention among veterans. The witnesses include VA officials and mental health experts. Things should be getting started shortly. You're watching live coverage on C-SPAN 3.
Tight quarters here. Good evening. I call this hearing to order. First, I'd like to welcome our witnesses this evening, Dr. Stone from the Veterans Health Administration, Dr. Avioli from the National Institutes of Health, Dr. McCune from the Substance Abuse and Mental Health Services Administration. Today's hearing will be the first of many this committee will hold as it begins the critical work to address veteran suicide. I think we can all agree how important it is to take care of our veterans, which is why I have made ending veteran suicide my #1 priority. Sadly, America is facing a national public health crisis that demands urgency from Congress, the administration, medical and clinical professionals, veteran service organizations, and veterans themselves. This morning, we lost another veteran to suicide at a VA hospital. 2 weeks ago, 3 veterans committed suicide on VA property in just 5 days. 7 veterans have ended their lives on VA campuses this year. It's clear we are not doing enough to support veterans in crisis. While these incidents may be alarming, they do not tell the full story of veteran suicide in our country. It is harmful to veterans and overly simplistic solely to blame VA for these tragedies. We must come together as a nation to address this crisis. Too many Americans have been personally touched by this troubling trend. For me, it was my own uncle, a Vietnam veteran who died by suicide. I still remember the day that I came home in September when I was 10 years old to find out that my uncle Sabado, a Vietnam War veteran, had taken his own life, and he lived across the street from my own family. His suicide still haunts me from time to time to this day. Each day, 20 veterans, service members, reservists, and members of the National Guard die by suicide. One veteran lost to suicide is one too many. But 20 deaths a day, totaling more than 7,300 deaths per year, is unacceptable. To put this in perspective, that's 1,800 more deaths per year than the 5,429 service members who have been killed in action since 2001. Both numbers are surprising and further evidence of a frustrating and persistent problem that we failed to adequately address. So, if I may move this poster closer. When you examine the statistics, barriers to access many veterans face become very clear. Only 6.1 of those deaths are veterans accessing services at VA. But 10.6 deaths a day are veterans not using the VA at all. And 3.8 current active duty or members of the National Guard are also committing suicide. We all have a responsibility. We all have the responsibility to act because there's no excuse for failing these veterans here at home. My Republican colleague, Ranking Member Rowe, often says, we haven't moved the needle far enough to reduce veteran suicide, and he's right. That number has held steady at 20 deaths a day since 2014 for far too long. It's time for Congress to look at this crisis with fresh eyes. In 2015, Congress passed the Clay Hunt Suicide Prevention for Americans Act, otherwise known as SAVE Act. But this well-intentioned effort hasn't done enough. Recently, I met with several members of Clay Hunt's unit who identified the specific challenges they faced as they transitioned out of the military. We need to understand why this legislation hasn't done more to prevent suicides. We need to expand our understanding of mental health among veterans. We need to commit to providing the resources needed to implement a comprehensive plan. Most importantly, Americans must hear from and listen to our veterans. We need to hear from veterans who have attempted suicide, understand their circumstances, and find out what they believe worked and what failed. These veterans have a story to share that can tell us something about our attempt to address suicide and how responsive government can be to their situation. This committee will not be indifferent to the problems veterans face, nor will we turn a blind eye to the many causes that lead veterans to committing suicide. And I'm glad that we could all come together today to begin to tackle this important issue. Ultimately, it's up to all of us to reduce and prevent veteran suicide because this is not a problem that VA can solve alone. We know that dedicated doctors, nurses, and VA employees saved over 240 veterans from committing suicide on VA campuses in recent years. VA briefs me on each suicide at a VA facility, and there's still so much that we don't know. We must involve partners at the federal, state, and local levels and do a better job of supporting veterans in need, regardless of whether that need is clinical or social. By supporting clinically effective programs and increasing access to programs that mitigate the impact of concerns, be they financial, marital, substance abuse related, or physical health, veterans will feel the support they seek. VA must also ensure that every interaction it has, not just in a clinical setting, makes veterans feel supported. One example from VFW struck me when I was reading the statements for the record from the VSOs. And I quote, "The VFW was working with a veteran who was rushed to a VA hospital during a mental health crisis caused by untreated bipolar disorder and depression. The veteran was admitted to the medical center's inpatient mental health care clinic for 2 weeks, despite not being eligible for VA health care. VA did save his life, but now he has a $20,000 bill. His mental health crisis was exacerbated by unemployment and his inability to provide for his family. With proper treatment, he has been able to return to work, but still lacks the resources to pay the VA bill. The VFW is working on having his bill waived, but he will never return to VA if he has another mental health crisis, end quote. Now, this is just one more testament to what we already know. When a veteran is faced with the sky-high cost of medical care, that can be a significant barrier to getting the help they need. To really combat this crisis, we will have to change our mission. We must re-examine our approach to suicide prevention, exhaust our research possibilities, break the stigma faced by those seeking mental health services, and expand the health care and support we offer veterans. Like all of those in this room, I believe Americans are ready to meet this challenge. Countering this crisis will require us to shine a national spotlight on veteran suicide. And there is still so much that we do not know. We need to better understand the root causes driving veteran suicide, hear from the families who have lost loved ones, and listen to the clinicians and social workers who are on the front lines battling to end veteran suicide. As Americans, we are proud of the service and sacrifice that they have made for our country. But a thank you for your service isn't enough for our veterans in crisis. Instead, we must thank and honor our veterans with action, work together to deliver top quality health care, provide community support, and ensure we offer a stable transition out of military service and into quality, sustainable employment. Truly thanking veterans for their service means helping them when they need it most and to rise above political opportunism to support veterans in crisis. It is my hope that together we can curb this crisis. Now, before I recognize Ranking Member Rowe, I'd like to point out that May is Mental Health Awareness Month, and we all have to do our part. I encourage every member of this committee to record a suicide prevention public service announcement to highlight VA's Be There campaign. As the Wounded Warrior Project pointed out, quote, if a treatment program does not offer a family or a caregiver component and warriors go through clinical processes when they return home, it may leave the family or caregiver to feel left out in the dark about what occurred, end quote. We should all be doing all that we can to ensure family members and caregivers not only feel supported, but have access to much needed resources as they help their loved ones recover. In addition, I would encourage all of you to meet with both veterans who are suicide survivors and speak with families who have lost loved ones to suicide to better understand how we can work to end this crisis. Now, at this time, I'd like to recognize my friend and colleague, Dr. Rowe, for 5 minutes for any opening remarks that he may have.
Thank you, Mr. Chairman, and thank you for holding this hearing tonight and also shining a light on veteran suicide. Tonight's topic is the most important, most confounding, and the most heartbreaking one that we will discuss in this committee. While suicide is a tragedy, no matter where it happens, it is particularly painful when it occurs on the grounds of a Department of Veterans Affairs medical facility with help mere feet away. The last several weeks have seen 4 incidents of suicide on VA campuses, including one just today in Cleveland. My heart goes out to the surviving family members and friends of each of these veterans, and I want them to know that they are foremost on our minds here in this Congress. Their loved ones are a part of approximately 20 of our nation's veterans, active duty service members, and members of the National Guard and Reserve who die by suicide each day. That rate has remained largely the same since the 1990s, despite 2 decades of sincere effort from administrations on both sides of the political spectrum and substantial increases in funding, staffing, programs, attention, and support for mental health care and suicide prevention inside and outside of the VA healthcare system. Since 2005 alone, funding for the VA mental health care has increased 258% to a high of $9.4 billion in the most recent request. Unquestionably, too little progress has been made. Unquestionably, a business as usual approach to this crisis is not sufficient. To be clear, the tragedy of suicide is a societal one that is in no way unique to VA or to veterans. Let me just give you an anecdotal description of why I know that's true. In my state of Tennessee, when I graduated from medical school, we had Eastern State, Central State, and Western State mental hospital. Those are all gone. As I went across my district and held town halls and roundtables this past 2 weeks, I met an EMT who told me that he worked in the ER on weekends. One weekend, he had a man there who was in a room waiting for a bed in a mental hospital. He came back a week later, and the man was still in the emergency room. For seniors, we have to transport people from Sullivan County, Tennessee, you don't know where that is, but to Memphis. And I can tell you it's 500 miles away. We do not have the mental health infrastructure, not just for VA, but for our citizens in this country anymore. And it's something we're going to have to learn to deal with as a nation. Of the 20 suicide deaths per day among our nation's heroes, 14 have not received, as the chairman said, VA health care in the 2 years preceding their deaths. This is a clear indication that VA alone cannot solve this crisis. I commend President Trump for issuing 2 executive orders in the last 2 years to rally federal, state, and local government agencies as well as non-governmental organizations around this issue. I look forward to the hearing today about how those executive orders are working and how their impact will be measured moving forward. I'm also looking forward to delving into an important concept that Secretary Wilk and his team, including Dr. Stone and Dr. Franklin, who are both with us tonight, have been stressing recently, and that is that suicide is not exclusively a matter of mental health. It's quite a bit more complex than that, and solving it will require nothing less than harnessing the collective efforts of every community around in need long before the crisis point is reached. Tonight's hearing would be incomplete if it didn't include a frank discussion about the role each one of us can play in our districts to stem the tragic tide of veteran suicide, and about the deeper personal and societal issues such as loss of purpose, belonging, and connection that far too many Americans, not to mention veterans, are struggling with. Our goal should be more than just preventing suicide. It should be helping our veterans to live a life of meaning and joy. I would like to also caution us all in having that discussion to resist narratives that paint veterans as victims or a tragedy of suicide is insurmountable. We know from research and experience that treatment works and recovery is possible, and that is the principal message that I hope everyone takes home tonight with them. I'm grateful for all of our witnesses and audience members for being here this evening, and I yield back, Mr. Chairman.
Thank you, Dr. Rowe. Appearing before us tonight is Dr. Shelley Avanavoli. And she is she's the Deputy Director of the National Institutes of Mental Health. Dr. Richard McCune. Excuse me, did I say your name correctly, Mr. McCune? McKeon. Dr. Richard McKeon, Chief Suicide Prevention Branch of the Substance Abuse and Mental Health Services Administration. Dr. Richard Stone, Executive in Charge, Veterans Health Administration, Department of Veterans Affairs. And accompanied by Dr. Keita Franklin, National Director of Suicide Prevention, Department of Veterans Affairs. And we'll begin first with testimony from Dr. Avanavoli. Dr. Avanavoli, you are recognized for 5 minutes to give your opening statement.
Thank you. Good evening, Chairman Takano, Ranking Member Rowe, and distinguished members of the committee. I am Dr. Shelley Avanavoli, the Deputy Director of the National Institute of Mental Health within the National Institutes of Health. It is an honor to appear before you today alongside my colleagues from SAMHSA and the VA. Given the troubling rise in the national suicide rate in the past decades, suicide prevention research is an urgent priority for the NIH. As the lead federal agency for research on mental disorders, NIMH's portfolio includes projects aimed at identifying who is most at risk for suicide, understanding the causes of suicide risk, developing interventions, and testing the effectiveness of suicide prevention services in real-world settings. In collaboration with our federal and private partners, we work to translate these research findings into evidence-based practices. Today, I want to highlight research that has identified promising suicide prevention tools ripe for implementation within healthcare systems. When used effectively and in combination, these tools may increase the number of lives saved among veterans and among all Americans. Healthcare settings are important for two reasons: access and opportunity. Nearly half of individuals who die by suicide had some type of medical visit in the 30 days prior to death, and around 80% did so in the year before death. In addition, about half of people who die by suicide had at least one emergency department visit in the year before death. NIMH-funded research has identified a growing number of evidence-based suicide prevention tools that can be used right now in these healthcare settings. I would like to walk you through a scenario that showcases how the healthcare system, using some of these tools, can identify more people at risk for suicide, provide effective treatment, and ensure appropriate follow-up care. So let's say you are depressed and feeling suicidal, but you haven't told anyone about these feelings. One day you have severe abdominal pain and you go to the emergency room. Your conversation with the doctor focuses on your physical pain. But because this emergency room screens all patients for suicide risk, the doctor asks you if you had had suicidal thoughts or attempted suicide. Our funded research shows that screening all patients doubles the number of people we can identify who are in need of help for suicide risk. So when you tell this doctor that you have been considering suicide, the doctor connects you with a social worker. The social worker asks questions to assess your level of risk, discusses treatment options with you, and works with you to develop a personalized safety plan. This safety plan describes approaches for reducing your access to lethal means, identifies specific coping strategies to decrease your risk, and lists people and resources that could help you in crisis. Safety planning is an evidence-based intervention, and we are currently supporting research on the best ways to deliver this in various settings and populations. As part of that safety plan, the social worker links you with a local crisis center that is part of the National Suicide Prevention Lifeline system. This crisis center works with your hospital to keep in contact with you by telephone over the next few months, a very high-risk time for suicide. An NIMH-funded study has shown that this combination of screening, brief prevention, and follow-up contact reduced suicide attempts in the next year by about 30%. A growing number of healthcare systems are implementing many of these evidence-based practices, but we know there is more we can do. Through the National Action Alliance for Suicide Prevention, the NIMH, SAMHSA, CDC, VA, and other public and private partners are working towards a goal of zero suicide deaths in healthcare, in which health systems implement these and other evidence-based practices. The Zero Suicide Framework includes comprehensive tracking of patient outcomes so we can monitor progress and identify additional ways to save lives. Today, I've highlighted just some of the suicide prevention tools our researchers have tested in the healthcare system. We are committed to working with our partners and stakeholders to ensure these evidence-based tools are implemented and accessible to all. Moving forward, we will continue to provide hope by supporting research to prevent suicide. I want to thank the committee again for bringing us together, and I'm happy to address any questions you may have.
Thank you, Dr. Avanavoli. Dr. McKeon, you're recognized for 5 minutes to give your opening statement.
Thank you. Chairman Takano, Ranking Member Rowe, members of the committee, thank you for inviting the Substance Abuse and Mental Health Services Administration to participate in this extremely important hearing on suicide prevention for America's veterans. I'm Dr. Richard McKeon, Chief of the Suicide Prevention Branch at SAMHSA. An American dies by suicide every 11.1 minutes. Suicide is the 10th leading cause of death in the United States and the second leading cause of death between ages 10 and 34. We lost over 47,000 Americans to suicide in 2017, almost the same number we lost to opioid overdoses. For each of these tragic deaths, there are grief-stricken families and friends, impacted workplaces and schools, and the diminishment of our communities. SAMHSA's National Survey on Drug Use and Health has also shown that approximately 1.4 million American adults report attempting suicide each year, and over 10 million adults report seriously considering suicide. As painful as these numbers are, our concern is intensified by the CDC's report that suicide has been increasing in 49 of the 50 states, with 25 of the states experiencing increases of more than 30%. While federal efforts to prevent suicide have been steadily increasing over time, thus far they have been insufficient to halt this tragic rise. We can only halt this rise nationally if we are also reducing suicide among the estimated 20 veterans a day who die by suicide, including those not in the care of the U.S. Department of Veterans Affairs. All of us must be engaged in this effort, and for this reason, SAMHSA includes language in our suicide prevention funding opportunities, prioritizing veterans, and has worked actively with VA on suicide prevention since 2007. While we have not as of yet been able to halt this tragic rise, we have seen that concerted, sustained, and coordinated efforts can save lives. One area where such a concerted national effort has been made is youth suicide prevention. Cross-site evaluation of our Garrett Lee Smith Youth Suicide Prevention grants has shown that counties that were implementing grant-supported suicide prevention activities had fewer youth suicides and suicide attempts than matched counties that were not. However, this life-saving impact fades 2 years after the activities have ended. This underscores the need to embed suicide prevention in the infrastructure of states and communities. Congress has also provided SAMHSA $11 million to focus on adult suicide prevention, with $9 million appropriated to the Zero Suicide Initiative. This is an effort, as my colleague has expressed, to promote a systematic, evidence-based approach to suicide prevention in healthcare systems, using the most recent findings from controlled scientific studies as part of a package of interventions that moves suicide prevention from being a highly variable and inconsistently implemented individual clinical activity to a systematized and prioritized effort. It uses the most recent science on screening, risk assessment, safety planning, care protocols, and evidence-based treatment. We've also been working through all of our suicide prevention grant programs to improve post-discharge follow-up, since multiple studies have shown that rapid contact after discharge from EDs and inpatient units is a time of high risk. The SAMHSA Suicide Prevention Program that touches the greatest number of people is the National Suicide Prevention Lifeline, a network of 165 crisis centers across the country. The National Suicide Prevention Lifeline includes a special link to the Veterans Crisis Line, which is accessed by pressing 1. Last year, more than 2.2 million calls were answered through the Lifeline, and that number has continued to grow at a rate of about 15% per year. However, the increasing call volume is also straining the Lifeline system of community crisis centers, which are responsible for responding to calls. SAMHSA and the VA have been working to prevent suicide. More recently, SAMHSA and VA have worked together to fund a series of mayor's challenges and governor's challenges to prevent suicide among all veteran service members and their family. We have convened cities and states and policy academies and implementation academies to promote comprehensive suicide prevention for veterans. Multiple public and private partners are engaged in this effort. As an example, in the Richmond Mayor's Challenge, the McGuire VA Medical Center and the Public Mental Health Center, Richmond Behavioral Health Authority, have developed a coordination and referral process to assure that veterans at risk don't fall through the cracks between VHA and community system. That work is now being implemented elsewhere in Virginia as part of the Governor's Challenge. We believe that this type of strong, continuing interdepartmental effort that incorporates states and communities as partners is necessary to reduce veteran suicide. In summary, SAMHSA is engaged in an unprecedented amount of suicide prevention activities. But we know we need to do more to play our role in halting the tragic rise in loss of life we are experiencing across the country. In particular, we know we need to be engaged in a strong, continuing, collaborative effort with the Veterans Administration and others to reduce suicide among our nation's veterans. We know we must be constantly looking to improve our efforts and to learn from both our successes and our failures. We owe it to those who have served this nation and to all those we have lost, as well as to those that love them, to continually strive to improve until suicide among veterans and among all Americans is dramatically reduced.
Thank you, Dr. McKeon. We'll now hear from Dr. Stone, who will be recognized for 5 minutes to give his opening statement.
Good evening, Chairman Takano, Ranking Member Rowe, and members of the committee. I appreciate the opportunity to be here to discuss the critical work VA is undertaking to prevent suicide among our nation's veterans. I am accompanied today by Dr. Keita Franklin, Executive Director of the VA Suicide Prevention Program. Suicide is a serious public health tragedy that affects communities across this nation, and recently this tragedy has occurred on the grounds of our VA healthcare facilities. In the last 6 weeks, 6 veterans have ended their lives on our healthcare facilities. Our facilities are designed to be places of safe haven for those who defended our nation. Although less than 0.5% of suicides occur at both VA and civilian healthcare facilities, these events highlight the important discussion that we will have here tonight. All of us at VA feel these losses as we have dedicated our professional lives to provide health care and enhance the resilience of our nation's veterans. The 2018 National Strategy for Preventing Veteran Suicide is a multi-year strategy that provides a framework for identifying priorities, organizing efforts, and focusing community resources to prevent suicide among veterans. This approach has 4 key areas. First, primary prevention that focuses on preventing suicidal behavior before it reaches the level of individual self-harm. Second, a whole health approach that considers factors beyond just mental health. Third, application of data and research that emphasizes evidence-based interventions. And fourth, collaboration that educates and empowers communities to propagate suicide prevention efforts beyond the VA. These efforts should move us from a crisis intervention focus to one that enhances the relational skills and resilience of our heroes. We know that an average of 20 veterans die by suicide every day. This number has remained relatively stable over the last several years. Of those 20, only 6 have used VA healthcare in the 2 years prior to their death, while the majority, 14, have not. In addition, we know from national data that more than half of Americans who died by suicide in 2016 had no mental health diagnosis at the time of their death. This is also true for our veterans. We also know that a massive expansion of VA mental health providers and increased mental health access has done little to reduce the total number of suicides among America's veterans. While there is still much to learn, there are some things that we know. Suicide is preventable, treatment actually works, and there is always hope. Maintaining the integrity of VA's mental health care system is vitally important, but clearly this is not enough. VA alone, without the help of all of you, cannot end veteran suicide. The VA has expanded its suicide prevention efforts into a public health approach while maintaining and expanding our crisis intervention services. We ask all of you to help, and we appreciate the public service announcements many of you have already recorded. VA is expanding our understanding of what defines healthcare by developing a whole health approach that engages, empowers, and equips our veterans for lifelong health, improved resilience, and improved well-being. VA is uniquely positioned to make this a reality for our veterans and for our nation. This effort is about enhancing individual resilience. On March 5th, 2019, the President signed Executive Order 13861, a national roadmap to empower veterans and end suicide, in order to improve the quality of life for our nation's veterans and develop a national public health roadmap to lower the veteran suicide rate. This executive order will further VA's efforts to collaborate with partners and communities nationwide and to use the best available information to support all veterans. We must partner with, empower, and energize all communities to engage veterans who do not use VA services. We are committed to advancing our outreach, prevention, empowerment, and treatment efforts, and will continue to improve access to care. Our objective, however, is to give our nation's veterans the top quality care that they have earned, wherever and whenever they choose to receive it. Mr. Chairman, this concludes my statement. My colleague and I are prepared to respond to your questions. With your tolerance, sir, I would like to do something that I did before, and I would like everyone that has not done so already to take your phone out and to type in the Veteran Crisis Line, 1-800-273-8255. 1-800-273-8255. You will be prompted to press 1 if you are a veteran, and you'll be connected to our professionals. You can also text 838-255, 838-255 to connect with a VA responder. Mr. Chairman, thank you.
Thank you, Dr. Stone. Let me say that Dr. Avanavoli, Dr. McKeon, and Dr. Stone's full written testimony will be included in the hearing record. Let us move on to the questions. I'll begin with myself. I recognize myself for 5 minutes, and my first question is for Dr. Stone. Dr. Stone, VFW's statement provides an example where a veteran sought immediate treatment at a VA mental health clinic because, quote, she feared that she would take her own life, end quote. The front desk clerk told her that she couldn't be seen immediately because she had completed a mental health appointment the previous day, and the next available appointment wasn't ready for a week. Thankfully, this veteran survived despite failing to receive the appropriate care. In contrast, at VA hospitals throughout the country, employees have responded by saving 240 veterans' lives when they walk through the hospital doors needing help. But let's put ourselves in the shoes of this woman for a moment. That interaction with the front desk clerk or a nurse or a police officer could have led her life to her life being saved, or led to that veteran going to the parking lot and committing suicide. How should the front desk clerk have responded? And how is every VA employee trained to recognize the signs of a veteran in crisis?
Mr. Chairman, clearly this veteran should have been seen. I'd be happy to review the events related to that if they can be provided to me by your staff. Secondly, let me reference the bill that was created for the veteran that you referenced. Certainly, I am very pleased that this veteran was admitted for a 2-week period of time, or at least that's my understanding. I'm deeply disappointed that the first I've heard about it is about this bill is in this hearing. I think it would have been helpful when I had breakfast with that VSO 2 weeks ago and discussed suicide. If we could have brought this to my attention, we could have alleviated 2 weeks of suffering for that veteran and his family. We will be happy to work with this. I can only assume that the lack of eligibility for payment for those services through our normal budgeting reflects something in the veteran's background that made him or her ineligible. But what should that front desk clerk have done? That front desk clerk has in all likelihood gone through SAVE training, which is training that we give to our non-clinical personnel to recognize issues that veterans should have been seen and then evaluated by a medical professional. It is notable that our police officers go through 30 hours of mental health training in order to recognize veterans in crisis. They also go through approximately 20 hours of actual scenario-based study in which they demonstrate their capability to diffuse and de-escalate situations. That has been recognized at our training academy, and a number of other federal agencies and police agencies have sought that training from us. I'll defer to Dr. Franklin if she has additional comments.
The only other piece I would add is that I appreciate the context of the question with regard to the front desk, because everybody has a role when it comes to preventing suicide, and anybody in the hospital system can do the right thing, and we're teaching them that through the training. We're teaching them to know the signs, know the symptoms, know what a risk is, and to take action at their level, regardless of what level that is.
Dr. Franklin or Dr. Stone, if I were to ask any VA employee at a VA hospital how they should respond when a veteran in crisis walks through the door, what answer would I get?
The answer should be yes. The answer should always be yes, and we welcome veterans to be seen. Every one of our sites, more than 1,000 sites, has same-day access for mental health services, regardless of veteran status.
Is every employee trained to recognize the signs of a veteran in crisis and to treat that veteran with compassion and respect?
Yes.
So, Dr. Stone, I appreciate that you brought up earlier the issue with the $20,000 hospital bill. My question was, how does VA prevent veterans from relapsing into crisis upon discharge, including the way in which VA bills veterans for the care they receive? And my question would be, wouldn't sending a veteran a $20,000 hospital bill send a veteran into crisis and create another barrier for care?
We certainly know, and this is part of my opening testimony, we certainly know that many of the issues facing veterans that lead to suicide relate to relational problems, relationship problems, as well as financial problems. And it's deeply troubling that we would generate this bill if there wasn't a secondary insurance that should have been billed.
So it's very important that VA is able to exercise its role as a central coordinator of care in these cases.
Absolutely, sir.
My time is up, and I'd now like to turn to Ms. Radewagen for 5 minutes.
Thank you, Mr. Chairman, and thank you, Ranking Member Dr. Rowe, for holding this very important hearing. I also want to welcome the panel. Thank you for all you do. My question is for Dr. Stone, and if anyone else has any comments, that would be appreciated. There has been a tremendous amount of attention devoted to the 3 recent incidents of suicide on VA campuses. Do you see any connection among these incidents? And do you have any evidence that they are symptoms of an increase of suicide among veterans, either in general or on VA property?
Each one of these incidences is a tragedy, and each one is an individual that we've lost. What's difficult to understand is that a number of these incidences have occurred in individuals that we hadn't seen for a number of years, but yet they arrived on our campus and underwent an act of self-harm resulting in their death. Clearly, as the ranking member pointed out in his comments, the fact that help was a few feet away is deeply troubling. But yet, even if we fix that problem, 99.6% of veteran suicides are not occurring on our campuses. Now, what do we know? We know that America has a problem on inpatient services, especially in psychiatric units, when there are not door alarms and wait alarms that can prevent suicides. We learned that lesson tragically in West Palm Beach less than a month ago when a veteran actually timed our nurses walking through to check on them and then committed an act of self-harm resulting in his death immediately after the nurse walked through to check on him. The lesson from that is that we're replacing every door across our system with weight sensors. Now, is it perfect? No, but it's the best that we have in order to correct this issue. What else have we learned? We've learned that some of these veterans come to our campuses because, and we know this from the notes that they've left, that they know they'll be taken care of, and they know their families will be taken care of. There are those that would like to indict the VA in this process. And I would caution you that this is not as easy as me having just a few more policemen to go through the parking lots or the parking structures. But this is about a whole of society approach that reconnects veterans that are intensely lonely and with a feeling of hopelessness that results in these acts of self-harm.
Does anyone else have any comments? My time is running out, but thank you, Mr. Chairman. I yield back.
Thank you, Ms. Radewagen. I now would like to recognize Ms. Brownlee, who chairs our Veterans Health Subcommittee.
Thank you, Mr. Chairman. And I wanted to do a quick follow-up to your line of questioning. Dr. Stone, you gave some very positive responses to the chairman's questions in terms of what the VA does vis-a-vis responding to a veteran in crisis. My question is, how do you know that you're 100% correct?
I can know because we tabulate on our training management system the amount of training that's been done. Now, we certainly have new employees coming on board that need training, but you would think that with the large amount of redundancy in our system, that there would be the possibility that each veteran would be able to be taken into our care effectively and without being turned away.
So training is enough in terms of ensuring that we have a 100% positive response to a veteran in crisis. I understand that there's turnover and that sort of thing, but it seems to me as though there needs to be more of that to know site by site that those things are actually being executed. That's my concern.
Congresswoman, thank you, and I appreciate it. It's my concern also. And I think that's why I mentioned amongst our police officers the ability to actually demonstrate empathy, to be able to demonstrate the ability to de-escalate a crisis situation is absolutely essential.
Thank you. Another question I had, the doctor from NIH laid out a program, an evidence-based safety program, I think that you called it. But basically, to quickly summarize, it's screening all patients, then a social worker drilling down a little bit more in terms of screening, and then obviously, if that screening tells the professional that a veteran is in crisis, then linking she or he with a crisis center, perhaps within the VA, perhaps within the community. And I think we all agree it's a community effort. So evidence-based program, effective, good results. Is this what we're doing in the VA every single day, screening every single patient, having a social worker do the screening, and then if need be, linking that veteran to services?
Yes, Chairwoman, that's exactly what we're doing. We've received those results from NIMH and we've implemented that enterprise-wide, exactly those three methodologies. Not only screening in mental health, but screening in every single clinic across the entire VA. If somebody gets seen in podiatry, they're getting a screen on suicide, make no mistake. And the safety plans across the board. This past year, we implemented a standardized safety plan protocol so that we could make sure that every safety plan that was done is done the same and is done with a high degree of rigor and evidence to the exact model that was briefed by my colleague, and follow-up contact through caring outreach, exactly following the research model. Yes, ma'am.
Thank you. And the last question I had was on military sexual trauma. So it's my understanding, it's been a while since I read the report, but there was an OIG report, I think it was in 2018, that talked about MST claims. And the report, if I recall it correctly, said that 60% of the MST claims were incorrectly denied, so that women and men perhaps were not receiving the benefits they needed. Obviously, MST is very much linked to the topic that we're talking about this evening. If you could tell me, can you respond to that and let me know what the VA is doing about it?
Congresswoman, certainly I represent VHA, not VBA, and I appreciate the question. And just to make sure that I have this right, we will check and get back to your staff to make sure that we answer this correctly. But my understanding is those denied claims are now all being reviewed to assure that they are accurate.
I would like a follow-up if you can provide it. I think it's of your interest, it's of our interest, obviously. I understand it's under VBA, but MST and the link here, I think is very important, and I think we need to actually have very firm answers. And my time is about to run out, but you mentioned in your testimony about a national network of women's health champions, which sounds to me like a new program. I don't have time to ask the question today, but I haven't heard about it and very interested to understand what it's about. I yield back.
Thank you, Ms. Bradley. I now recognize Mr. Belarakis for 5 minutes.
Thank you very much, Mr. Chairman. I appreciate it. Thank you for holding this hearing. I want to thank Dr. Rowe as well. Thank you for your testimony. Appreciate it so very much. Dr. Franklin, quickly, what about screening more intensely for suicide awareness at DOD? Any comments on that?
Screening more intensely with DOD?
DOD, yeah.
Yes, we have there was an executive order that was pushed out in this past year, not the one that Dr. Stone mentioned in his testimony, but an earlier one. And this executive order calls for increased screening from DOD so that when troops are leaving the active duty side, they have eyes on by a medical provider, and those results are immediately pushed over to our mental health teams over on the VA side, so that there's an accurate view on the service member's mental health status before they leave active duty.
Okay, very good.
Let me add just a little bit to that. I think this is absolutely correct. But in that first executive order, the ability for us to interact with a service member in the year before they leave active duty is absolutely essential. And the authorities you've granted us in allowing us to see service members for that first year after they come off active duty is an absolute risk reduction. I would ask the committee to take a deep look at the work that's been done since the late 1990s in the Air Force that has actually integrated resiliency, relationship-based training, and suicide awareness amongst all active duty and reserve members of the Air Force. The Air Force has not seen the increase in the number of suicides that a number of the other uniformed services have. So this interaction and potentially modeling after the Air Force training is absolutely essential.
Very good. Well, I'd like to work with you, sir, on some legislation with regard to that, because I think that would make a big difference. I really do. Let me ask another question. I do have some prepared questions too, but I don't know, we don't have a lot of time. Can you tell me, and you may not have some statistics on this, but prior wars, prior eras, let's say the Vietnam era, even going back to World War II, give me some statistics with regard to suicide rates. How did we compare to what's going on today, the 20 a day, which is obviously one is much too high as far as I'm concerned. Can you give me any stats with regard to that? For instance, the Vietnam era, as far as the suicide rate is concerned.
Yes, absolutely, Chairman. The data collection has gotten better over the years, so sometimes it's difficult to compare data across war efforts. We've only recently gotten a lot more savvy with our data and surveillance efforts. But what I will tell you is that when we look at our current effort, we see our highest rate of suicide right now amongst 18 to 34-year-olds. When you look at the rate per 100,000, and we see our highest raw number amongst men over the age of 55, which we suspect comes from that other era or that other war effort. And so we also know that we have more veterans in that group or in that category. And so that's what I offer, and I turn it back. Dr. Stowe may have more context.
So with regard to, how about percentages? You say you have more veterans in that category, but how about percentages?
So 21%.
I mean, we're spending more money, we have more programs, but evidently it's not doing any good.
So 21% of the suicides that we experienced in 2016 were in veterans over 75 years old.
All right.
When I add the 55 to 74 to that first group I mentioned, it adds up to over 60% of the suicides amongst veterans in this nation. Clearly, we need to recognize the fact that of the 20.4 million veterans in this nation, 77% have experienced combat. And the long-term effect on these veterans cannot be underestimated. Now, I grew up in a generational home. We were multiple generations had been in that home. Everybody on that street were generational homes. I couldn't walk out the front door as a young child, but yet I had 20 moms that were up and down that street. Just think about the neighborhoods that each of us live in today and recognize the isolation that many of us feel. I've lived in my current neighborhood for 4 years. I know the neighbors on either side. I've been in their homes, no one else. Counter that to on-base housing that I experienced on active duty. When my family and I moved into a home, every single family in the neighborhood came to bring us food, to make sure we were all right. Did we need anything? And every weekend after that, for weeks, we were welcomed into their homes until we became firm members of that community. This is a profound difference that we're seeing in all age groups of veterans. Certainly, the 18 years of combat that we've experienced in the current environment has taken a tremendous toll on veterans under age 35. But make no mistake that the increased suicide rate amongst veterans affects all age groups.
Thank you, Dr. Stone. Thank you. Let's try to keep our comments within the 5. We have a lot of people to get through, but I allowed you to go on because it was so compelling what you were saying. Let us move on to Ms. Rice for 5 minutes.
Thank you, Mr. Chairman. And thank you all for coming here to testify tonight. So I want to talk about an issue that I don't think that we can adequately address the issue of suicides amongst veterans without talking about guns, firearms. If you look at, there's no question that firearms are one of the most common means of completing suicide among the general population, and 69% of veterans have completed suicide via firearm. Women veterans are also more likely to utilize firearms in the attempt and/or completion of suicide than their civilian counterparts. It's been proven that restricting access to firearms may reduce suicide rates. So this is for anyone on the panel. Has the VA studied gun violence in the veteran population? what research is currently available on gun violence in connection to suicide. I'm well aware that we as a body, Congress, has not been willing to fund a study to look at the overall reason for the epidemic of gun violence in this country. But since we're talking about the VA, I'm specifically asking about the VA. Is this an issue that warrants more research to shed light on why firearms are the most common means utilized? And what resources does VA offer to veterans that may choose to limit their access to firearms? So anyone who wants to answer that.
Well, to put it in a national context, let me mention a couple of things. So 51% of all suicides in America utilize a firearm. So it is clearly a very important issue. The collaborative safety plan that Dr. Avanovoli spoke to includes as part of that paying attention to access to lethal means when working with an individual who is suicidal. That frequently includes firearms, can also include things like access to large amounts of pharmaceuticals or other dangerous substances. SAMHSA, through our Suicide Prevention Resource Center, has an online course on counseling about access to lethal means. Again, this is within the context of someone who's suicidal and trying to reduce access to lethal means on a temporary basis. And then finally, I would mention that a number of our SAMHSA grantees are doing work with firearm-owning groups and things like what is called the Gun Shop Project, working with them and with other groups to try to have a collaborative effort to educate about suicide warning signs so that people know how to respond.
And the only other thing that I would add from the VA side, we're working hand in hand with SAMHSA on many of those initiatives that Dr. McEwen spoke about. We also train our mental health providers with a special training on access to lethal means and how to talk with veterans about this issue. We do have a partnership with the National Shooting and Sports Foundation, and this is a partnership that helps us execute trainings in local communities with gun shop owners on signs and symptoms of suicide risk. And then we do work on this issue around putting time and space between the person at risk and any means that's lethal. And certainly firearms are the top means in our population, as you note, but equally so medication and a host of other issues around this topic.
Dr. Stone, you mentioned before, you used the word ineligibility. And to me, I just think it is the most insane policy that there is any man or woman who wore the uniform of this country and is, I don't care what they did, is ineligible for some kind of, for access to health care. I wonder, Dr. Stone, if you can tell us what specific risks other than honorable discharges represent because of their limited access to VA mental health care services, specifically women veterans who are more likely to have experienced MST, are also more likely to have received a bad paper discharge as retaliation for reporting MST before the 2-year mark when they would be eligible for VA healthcare. So I think this is an issue that we need to talk about in terms of, I just don't think that there should be a veteran and ineligibility should never go hand in hand.
I think, Congresswoman, you're exactly correct. And one of the big problems that we have, as the chairman identified in his opening statement, is never activated guardsmen and reservists. They've never been called to federal service, so technically they're not a veteran. And I'm not eligible to welcome them into the system. Now, we've tried to overcome that by using our vet centers and combining, and we've worked very successfully with the Guard Bureau and the Army Reserve to try and move our vet centers on a mobile basis into drill weekends. But many of the suicides we're seeing in never activated guardsmen and reservists are between age 35 and 54. So they're long since their service days. And how to reconnect with them or to give us the authority to engage them. It seems to me that if I can accept veterans with other than honorable paper, we ought to be able to accept the never activated Guard and Reserve who account for about 2.5 to 3 of the daily suicides that we're seeing.
Thank you, Dr. Stone. I think it's a conversation we should continue to have. And thank you, Mr. Chairman.
Thank you, Ms. Rice. Those are really great questions. Mr. Boast, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Thank you for having the hearing tonight. I think just real quickly, there's something that I should bring up. You know, because it came up during the last questioning. You know, losing one veteran to suicide is tragic, and I know none of us take it lightly. That being said, the veteran's Second Amendment right, and the ability to take that right away from them will not stop one of them from attempting suicide, and in fact, may discourage them from seeking help through the VA or through other means if they believe that they might lose that right. And I think that's a concern. It depends on where you're at in the country, but I know where I'm come from, and many of them have expressed that concern to me as well. We're all committed to preventing suicide, and I'm dedicated to ensuring that we are appropriately educating at-risk service members and veterans and their families about firearm safety and providing them meaningful support to help them overcome the struggles that they face. But as I said, I do believe we want to be very, very careful when we go down that road. But Dr. Stone, you actually, I think you answered part of this, but I'd really like to know, because you referenced in your testimony the president's executive order from last year, and I wanted to thank him for signing that, but ask you, what, if any, outcomes and lessons have been learned from the EO since it was signed, especially when the veterans are being screened from benefit from the VA and going on through the TAP program at DOD? What are we gleaning from that?
What we're learning, and I mentioned a bit about the Air Force experience that is incredibly intriguing, but what we also learned is that the more veterans and service members learn about our services, the more they engage us. And it is absolutely right thing to do for us to be engaged with them well before they get out of uniform. Now, certainly when you're sitting at the discharge station getting ready to get out, you don't want to hear very much. But in that 6 to 12 months before, it is time for us to engage. And the active services have all been very gracious in giving time for our staff to come in and talk about access as well as risk for that service member in the year after they leave service. You know, I discussed earlier the difference in American society on the civilian side versus American society in uniform. These are dramatic changes for the service member who may have experienced 10, 15, or 20 years in uniform.
And believe me, I'm not criticizing when I go down this next path, okay? I'm trying to figure it out as a member of this committee, and I'm sure this whole committee has asking this. You know, the VA is, but once again, back before us and telling us that combat veteran suicide is a top priority for the VA. As your budget continues to increase, suicide prevention money, we're giving more money towards that. But what actual results can be seen from the funding level that we're putting out there? We're not changing it. We're still at that 20 a day. We've got to come up with the ideas that truly change this. Not only we've got to figure out that if we're increasing money, we're not changing it. We're increasing programs and we're not changing it. How do we become really effective and bring those numbers down? Now, I know that you brought up the fact of the age, and the concern of the age too is where are we at when they commit suicide? What other things might be going on in their lives? Do we monitor that? Do we know those statistics? And how do we bring it down? Because every year we can come back and talk about it, but if we don't change the numbers, and we can raise the money every year, but if we don't change the numbers, we're not helping them.
Certainly, I can't disagree with your statement, Congressman. But I think the message here is that if this was 10 years ago, this would have been a $4 billion budget, and I'd have half the number of mental health providers that I have today. We have same-day access to mental health services, but we haven't changed the numbers. Now, there are those that would argue that maybe we have. Maybe this would be worse as a crisis if we didn't have 24,000 mental health professionals ready to see you today as a veteran. If, in fact, this is not the answer, then we have some hard looks at each other and hard looks at ourselves in the mirrors about what society has become. And I mentioned that in the generational home that I mentioned earlier. These are very tough discussions to have. We do know that the incredibly high rates of military sexual trauma, intimate partner violence, substance abuse, mental health disorders lead to a dramatic escalation in female veterans, as was mentioned by some of your colleagues earlier. We know also amongst all veterans that it is in the 2 weeks before becoming homeless, the rates of suicide go up dramatically. We also know that for veterans that are involved with the justice system, the month after they've been incarcerated, after they get out from incarceration, dramatic levels of suicide. But this is true across all of American society. Frankly, that's a worldwide phenomenon.
Thank you.
Thank you, Mr. Bost. I now recognize Mr. Lamb for 5 minutes.
Thank you, Mr. Chairman. Dr. Stone, I want to thank you for mentioning the whole health programs in your testimony and for being a supporter of those. I also have been struck by the potential in the VA's whole health program, and I got the chance to visit the program at the DC VA hospital, I believe it was last summer. And it's just a really promising area, and I just commend the VA for pursuing it and being innovative and risk-taking with that. And what struck me about it was not just the value of the services themselves. I think what we saw was acupuncture, meditation, yoga, and a couple other things. But you used the term empowering veterans. And what it really did was it gives veterans an active role in managing their own healthcare. It basically gives them a bunch of great, non-traditional, somewhat unusual options and says, pick from these yourself, and whichever one you like or you find valuable, keep coming back. And that was how they were running it. And you could tell that from that, a little community arose, and some of the same veterans would keep coming back to the same classes as they were able to, and they got to know each other and were looking out for each other and everything. And I think that, when we were there, it was mostly older veterans, but I think there's a lot of potential to use a program like that to attract some of the younger veterans into the system, because military members on active duty now are being trained in some of this same stuff. DOD has been pretty good at getting some of these things out there. So I think people are more used to it. So I have introduced legislation to try to expand the availability of whole health within the VA. And I'd love to have your support on that. But I was just hoping that either you or Dr. Franklin could talk about any connection you believe exists between the availability of the whole health programs and your suicide prevention efforts, how those can go hand in hand. Thank you.
As we modernize the VA, Congressman, one of the 10 lanes of effort is to expand across the entire enterprise, the whole health model. One of the things our colleagues have delivered in knowledge is an understanding of the role of physical exercise or the participation in team-based sports at any age as a dramatically preventative activity in reducing the suicide risk. And I'll defer to Dr. Franklin if she has other comments.
I appreciate your thoughts on the whole healthcare, and I'm eager for us to execute it across the enterprise. It started with the 18 flagship entities, one of which you may have visited, and it's well underway for full execution across the enterprise. And this notion of focusing on the social determinants of health and thinking about veterans in the context of biological, sociological, psychological, and spiritual, and allowing them to drive their care is the future of the organization. So I definitely appreciate it.
Thank you both for your work on that, Mr. Chairman. I yield back.
Thank you, Mr. Lamb. Mr. Bergman, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Thanks to everyone for being here. This is a subject that I know all of us take very seriously. And I'm not sure which one of you gave the following stats, so I apologize for that. Second leading cause of death in the age group 18 to 34. What's number 1, 3, and 4? Any ideas?
Well, in that age group, number 1 is accidents.
Okay.
And 3 is homicide is either 3rd or 4th. But I don't remember exactly. We can certainly get that for you.
Okay, well, and also in that, regardless of what's 1, 2, 3, and 4, is there from a gross standpoint, big numbers, not finite data, is there any huge percentage difference? Now, accidents are accidents, but any significant percentage differences in like 3 and 4, which is all of a sudden just a drop off?
Well, I think that one thing to remember, for example, is that while accidents may be at times very random, they are.
I don't want to. I don't want to waste time on accidents.
Okay.
That's okay. We try, and the bigger point here is a relative perspective of where it fits in causes of death as we talk to people and talk to other entities and figure out where to put, if you will, finite resources towards solving problems. An example, isolation we know causes potential suicidal ideations. Back when some of us with gray hair entered the military, there were military barracks. You had the communal living where you had your bunkmate. You had that. Now we have private rooms, if you will, once you reach maybe E4 or E5, and that idea we're not able to have eyes on our fellow military members regardless. So, differences when it comes generationally to when it talks about the community, the neighborhoods. You know your neighbors or you don't know your neighbors. Well, do you know your platoon mates? Do you know the people after you leave? Are there the associations? So I think there's differences societally here as we look at dealing with mental health. State-sponsored programs. Do states have different programs that you can refer to as examples of how it's being done very well? Some states versus others, not that we need to know, but are there best practices being shared when it comes to, the one size fits all when it comes out of Washington, D.C. may not resonate in in northern Michigan or isolated areas or somewhere where are more rural than urban. But are there any things you do to compare and contrast and take best practices?
I would mention a couple of things. Many states are making strong efforts for suicide prevention. An example of that is what's called the Colorado National Collaborative, which CDC has also been very engaged in. The idea there is to try to promote suicide prevention in a comprehensive public health way and to bring it down to the local level. And again, it's something that's being driven by those states and communities. There is federal funding that is being utilized.
I guess the question, because I got my time is running short and I got a couple quick questions, but as long as we can see that best practices are being captured and then put out so that we gain from it, not just a one size fits all perspective. And as